Hi guys, Dr. Patil here, and today we will be learning about idiopathic inflammatory myositis, or what we also recognize as inflammatory muscle disease. Okay, from this topic, particularly there are two important MCQ areas. One is the various antibodies that we encounter in these patients and their clinical correlations. For example, like what antibodies are particularly associated with the malignancy, what antibodies are associated with the cardiac involvement, or what antibodies are associated with skin involvement, or what antibodies are associated with increased ILD risk. This is the standard template of MCQs from this topic so far. You can also anticipate some image-based questions mainly focused on skin signs. There are a lot of important skin signs to learn. Yeah, obviously, when I'm talking about skin signs, I'm talking about the dermatomyositis variant. And also, they might ask certain image-based questions with respect to muscle biopsy findings, right? Okay, so that is the basic things we need to know. Now, before we start discussion on the topic, let me tell you that some of you might find this topic a little bit difficult because we have moved on. Like previously, we used to follow this Bohan and Peterson classification. We used to follow this Bohan and Peter classification for the disease, where you used to call it as dermatomyositis, polymyositis. So if you have skin and myositis features, then you call it as dermatomyositis. If you don't have skin features, you call it as polymyositis. And then we had overlap myositis, where patients had both involvement of the myositis features plus another rheumatological disorder. Then we used to call it as overlap myositis, or what we currently consider as mixed connective tissue disorder. Then if it is associated with malignancy, we used to call as cancer associated myositis. And if it is occurring in a juvenile or in a pediatric age group, we used to call it as juvenile dermatomyositis. But this classification system is no longer followed, right? So today we classify these patients based on their antibody profile, and every now and then we do correlate with the conventional classification system, and that is why it becomes a little confusing. But if you pay the attention, or maybe if you just revise through 1 or 2 times, everything will start falling in place. Okay, now what are these idiopathic inflammatory myositis? This is how I define it: as a group of heterogeneous autoimmune inflammatory systemic diseases. So pay attention, I'm saying systemic diseases because these are the disorders where antibody mediated injury is also affecting other organs. This is not muscle specific disorders, right? Systemic disorders characterized by weakness of muscles and, as I said, other organs, right? So this definition brings in all the conditions which we will be discussing today under one umbrella of idiopathic inflammatory myositis, right? Or inflammatory muscle diseases. Okay, now coming to the epidemiology of this disorder. Generally, when we talk about autoimmune disorders, obviously we say females are generally more prone than males. So is in this case also. Females are considered more prone to develop IIMs than males, with a ratio of 2 to 3:1. Generally, you can remember 3:1 as a rough rule, right? With one exception. The exception is inclusion body myositis. Now remember, inclusion body myositis will continue to occur as an exception throughout this session, right? So in fact, it is such an exception that some of the authorities also consider inclusion body myositis as not an IIM, but instead a degenerative muscle disorder. There are some valid reasons to think so. We will discuss more about it as we go along. Okay, so females are more prone with a ratio of 2 to 3:1 in comparison to males, except inclusion body myositis, where the ratio is reversed, exactly reversed. So you see one female involved for every 3. So there is, again, it is 3:1, but it is flipped. Male to female is 3:1. Okay, and then if you look at the age of presentation, most patients of the in idiopathic inflammatory myositis present before the 5th decade, right? So they are usually under 50s at the time of presentation. The average age of presentation is 40 to 50, that range, right? With an exception being inclusion body myositis. So inclusion body myositis is primarily diagnosed in elderly people. All the more reason to call it as a degenerative muscle disorder, right? Elderly people. Usually patients are 50 plus at the time of diagnosis. Okay, now that we're talking about the age, let me also tell you that overlap syndrome and dermatomyositis are the ones which can occur in pediatric age group. When they occur in the pediatric age group, particularly dermatomyositis, we call it as juvenile dermatomyositis. Okay, overlap can occur in any age group. The dermatomyositis under 50, pediatric age group also. Polymyositis typically adults. Okay, so with that, let us now discuss the classification. I've already told you we had something called as Bohan and Peter classification in the past, which is no longer followed. But for the sake of exam, we should be aware about what are those categories. So we will just spend 2 minutes behind that. Okay, so category number one is dermatomyositis, where there is muscle plus skin changes, right? There is myositis plus classical diagnostic skin rashes present. Then when the skin rashes are not present, otherwise it clinically resembles dermatomyositis, except that the skin rashes are not there. We used to call it as polymyositis. Then we had an entity called overlap myositis, cancer associated myositis, that was one type. And then the last one was juvenile dermatomyositis. This is the traditional classification system. Now today what we follow is ACR EULAR 2017 classification, where the disease is classified based on clinical picture plus antibody profile. Okay, that is the approach we follow. So in this system, first thing we note is what is the patient's age. If the patient is a juvenile or is belonging to a pediatric age group, then we have most common cause for inflammatory myositis in pediatric age group is juvenile dermatomyositis. So we will just see if there are skin manifestations. So if patient has heliotrope rash or Gauton's papules or Gauton's sign, these three are considered as diagnostic cutaneous manifestations of dermatomyositis. So if they are present in a patient who is under 18, we will diagnose it as juvenile dermatomyositis. If they are not present, then the diagnosis would be juvenile myositis other than JDM. Okay. On the other hand, when we are dealing with an adult patient, 18 plus, right? When we are dealing with 18 plus, if they have skin manifestations, the same thing that I am talking about, heliotrope rash, Gauton's papules or Gauton's sign, if they are present, then we will see whether the muscle manifestations are there. Now, obviously, when we say idiopathic inflammatory myositis, they are generally, with the exception being inclusion body myositis, they are generally proximal and symmetric, right? So when you have objective evidence of symmetric weakness, usually progressive of the proximal upper extremity muscles or proximal lower extremity muscles, or you have neck flexors which are relatively weaker than the neck extensors, or you have the weakness of the leg proximal muscles in comparison to distal muscles. Well, in simple words, you have proximal myopathy, right? In that case, you would be considering the diagnosis of dermatomyositis, because we had skin changes and we have muscle weakness evidence. We will call it as dermatomyositis. But very rarely, some subset of patients may not have the weakness of muscles at presentation. In those cases, when they have skin changes plus when they have skin changes but no muscle changes, we will call it as amyopathic dermatomyositis, right? Remember this terminology. We call it as amyopathic dermatomyositis because only skin changes are present. There is no objective evidence of the symmetric proximal weakness. Okay, so that is clear. Then when you don't have the skin changes but you're still considering it as the inflammatory myositis, in that case, look at the clinical picture and if required, do the biopsy and get evidence. Particularly the biopsy findings for inclusion body myositis are very classical. You generally don't miss it. So you will see something called as rimmed vacuoles when you use a Gomori trichome stain, rimmed vacuoles, and you can have inclusion bodies. When they are present, then the diagnosis is inclusion body myositis. And obviously, we're also looking at the clinical features. So if it is someone who is 50 plus presenting with myositis, you would be considering IBM as a possibility. On the other hand, clinical features might point you to think of polymyositis or immune-mediated necrotizing myositis. Based on what? Based on the history of exposure to drug, you will be considering IMNM, or if it is someone who has presented under 50, adult, not a pediatric age group, and you don't have skin features, then obviously you will be considering polymyositis as your diagnosis. Okay, so that is the approach. Okay, now coming to the antibody profiles, this is particularly very important for the exam. A lot of MCQs can be asked about it, so please pay attention. Let me start with classification of these antibodies. We can divide these antibodies into myositis specific antibodies, what we call as MSAs, then myositis associated antibodies, MAA, and others. Okay, these myositis associated antibodies are not specifically seen only in myositic conditions like we're talking today. They can be seen in various other rheumatological disorders. That is why we call it as myositis associated antibodies. Actually, what I have written is here is a very small number. You will come across a long list of such antibodies in different textbooks, right? So if you look at all these antibodies, for example, anti-PMSCL antibody typically seen in patients with systemic sclerosis or mixed connectivity disorders, or anti-CO antibodies, or anti-U1-RNP or anti-U3-RNP, mostly they suggest or they point towards overlap manifestations, right? Overlap syndromes. Other than that, you have other antibodies which can also be summed under a separate heading called other. For example, anti-Rho antibodies. Right? I'm just giving you an example. But our area of interest is these myositis-specific antibodies, and under that we have four broad groups. The group number one is anti-synthetase antibodies. Okay. When I say anti-synthetase antibodies, these are the antibodies which are primarily directed against what we call as amino acid tRNA synthetase antibodies. Okay, now definitely that means there are different types of tRNAs coding for different amino acids, and many of them can be targeted. Now overall, this is the most common antibody that we see in patients with IMDs. This is the most common, right? This is seen in more than 20% of overall patients, and when you look at the dermatomyositis or polymyositis, obviously the number increases, right? Now among these different tRNAs, the one that is involved in histidine, right? Histidine tRNA synthetase is the most common, which is also recognized as anti-Jo antibodies, right? So when you have this anti-Jo antibodies, we typically call it as anti-synthetase syndrome, right? So you should be aware about this word. We call it as anti-synthetase syndrome. We will talk more about it later, but right now remember that. Now this anti-synthetase antibodies, particularly the anti-Jo antibodies, correlate with various things, and that is one important MCQ point, right? It correlates with presence of, it is seen more in polymyositis than dermatomyositis. That is first point I want you to note. Second, it correlates with the risk of interstitial lung diseases. It correlates with the risk of mechanics hand. We call it as mechanics hand, one of the skin manifestation. It generally correlates negatively with other classical dermatomyositis skin manifestations. That is why I told you PM is more strongly associated than DM, right? Okay. Then the next thing we're talking about is anti-signal recognition peptide, what we also call as anti-SRP antibodies, right? We call it as anti-signal recognition peptide or anti-SRP antibodies. Now this correlates strongly with, this is also seen more in PM than DM, and this strongly correlates with disease activity. Obviously something that correlates with disease activity will correlate well with the prognosis, right? Prognosis, and this also correlates with the cardiac involvement. Okay, now we come to the third set of myositis specific antibodies, what we call as anti-helicase antibodies. Traditionally what is considered under anti-helicase is the anti-Mi2 antibodies, but apart from that we have other set of antibodies that can be considered under the same heading, that includes anti-TIF1 gamma antibodies, then anti NXP2 antibodies, right? These are all anti-SAE antibodies. Okay, now these are all very specific for dermatomyositis. So remember this point, right? So this anti-helicase group, the anti-Mi2, anti-TIF gamma, anti-TIF1 gamma, anti-NXP2 and anti-SAE antibodies, these are all associated with dermatomyositis. So they correlate with skin changes also, right? Then another point I want you to note is this anti-TIF1 gamma and anti-NXP2. They correlate with the malignancy risk. They correlate with malignancy risk. Okay, so that also means dermatomyositis, which these are specific for, is more strongly associated with malignancy than polymyositis. Yes, that is a true statement. Okay, among these two, anti-TIF1 gamma and NXP2, anti-TIF1 gamma is considered as more of a specific marker of malignancy, right? So this is one that is something that you should remember, you cannot afford to forget. Anti-TIF1 gamma strongly correlates with the malignancy risk. Okay, now coming to the last one, anti-melanoma differentiation associated antibody, or what we also call as anti-MDA5 antibodies, right? Now this is the one which is associated with the worst possible prognosis. Okay, what does this correlate with? This anti-MDA5 antibody correlates with the risk of development of interstitial lung disease. So interstitial lung disease, when you have anti-MDA5 antibodies, is likely to be extremely severe and rapidly progressing in comparison to ILDs that you develop in association with anti-synthetase antibodies, right? I hope that point is clear. Okay. Now, another thing that this correlates with, anti-MDA5 antibody correlates with, is with the risk of developing pneumomediastinum. Pneumomediastinum. Okay, so that is about the antibody profile. I think whatever points we have covered are very, very important from the MCQ perspective. Both if you're trying for INISS, the RUMAT, as well as if you're trying for the NEET PG, the NEET SS, this is going to be very, very important. Okay, this is a table from Kelly's which again summarizes whatever we have discussed. Anti-synthesis antibodies more common in polymyositis. I made that clear than dermatomyositis. It correlates with interstitial lung disease, arthritis, mechanics, and these points I've already covered. Yeah, the point that I missed is it also correlates with the risk of developing Raynaud's phenomenon, right? And interstitial lung disease, I think I did tell you. In simple words, you can remember having anti-synthesis antibodies makes your myositis behave like systemic sclerosis, right? So all those Raynaud's phenomenon, very like interstitial lung disease risk going up, or fever, mechanics hands, certain hand changes. So it makes it behave like systemic sclerosis. This way you can remember it in the exam, right? Okay, that is one point. Then anti-signal recognition peptide we just discussed. Polymyositis, it is more closely related, more severe disease and cardiac involvement. I think I did cover those points. Coming to this helicase group, right? Me2 as well as the anti-TIF1, TIF1 gamma and anti-SAE and anti-NXP2. Right. These are the things I want you to remember from this. They are specific for dermatomyositis. TIP1 has the strongest association with malignancy. NXP2 is also associated with malignancy. Right. I hope you will be able to remember, because you might get questions where they ask you which of the following antibody is specific for dermatomyositis. Right. Already these are considered as myositis specific, but within that it is specific for dermatomyositis. So, or they might ask you which of these antibodies correlate with the cutaneous manifestations, right? Okay. Now, once we know about the antibody profile, let us talk about clinical features. The first part I'm talking about is cutaneous manifestations. Obviously, they apply only for dermatomyositis, right? So, when it comes to cutaneous manifestations, we will have certain rashes which are considered as diagnostic rashes, and we have rashes which are considered as non-diagnostic. So, when it comes to diagnostic rashes, we have three things. One is Gottron's papules, heliotrope rash, and the other one is Gottron's sign. Gottron sign. Gottron sign is nothing but any cutaneous rash that is not Gottron papule will be called as Gottron sign. Okay. What is Gottron papule? These are flat-topped, raised, scaly, erythematous rashes typically seen on the dorsum of the hand, mainly present on the interphalangeal and metacarpophalangeal joints, right? You can clearly appreciate here interphalangeal and metacarpophalangeal joints, sparing the phalanges. This point is particularly important because a very similar looking rash you might get in patients with SLE, where it is primarily affecting phalanges and it will be sparing interphalangeal joints. That point helps us to distinguish, because otherwise those patients may also come with myopathy features. Those patients may also have some degree of arthritis, so it may be difficult to distinguish in that case, right? Then the second important diagnostic rash is heliotrope rash. Heliotrope rash, which is nothing but you are all familiar with this, a violaceous hue and erythema around the periorbital structures. So sometimes apart from this violaceous rash, they may have the periorbital, particularly lid edema, right? They may have eyelid edema also in a very subtle form. That may be the initial manifestation of this heliotrope rash. So these two are considered as diagnostic rash. Another thing that is considered as diagnostic rash is Gottron's sign, or you can also call it as Gottron's rash. So Gottron's rash is a very similar rash, but usually not on the dorsum of the hand, elsewhere. Again, typically seen in extensor surfaces, mainly on the bony prominences. It can be seen anywhere, but most cases it is seen on the bony prominences. Okay, so these are diagnostic rashes. In this image, we will be seeing some non-diagnostic rashes which are not very specific but can be seen or usually seen in patients with dermatomyositis. What we are seeing in the first image is what we call as linear erythema or linear rash, right? We call it as linear erythema. So as you can appreciate, there is a contiguous erythema without any major skip areas, linear, that is why we call this as linear erythema. Okay, that is one thing. This can also be again seen in patients with SLE, so not very specific, that is why we're not considering it as diagnostic rash. Then in the second image you can appreciate there is some degree of erythema in the scalp, so scalp erythema is also common in these patients. Okay, what we see in the third image is what we also call as V sign. So you might notice there is a distribution of erythema in the shape of V, that is why we call it as V sign. The same thing occurring on the back, we call it as shawl sign, right? We call it as shawl sign. So these are the four signs. You should be able to identify these images: linear erythema, scalp erythema, V sign, and shawl sign. Okay. Now let us go to the next set of images. What we appreciate in this image is, the first image is obviously typical Gauthron's papule, right? Typical Gauthron's papule. You can notice it is mainly on the interphalangeal joints and metacarpophalangeal joints, right? It is not affecting the phalanges, right? Okay. In the second image, we can see the lid edema, which is the early manifestation of heliotrope rash, right? Okay. What we see in the third image is a rash, flat topped, slightly scaly rash on the knee. I was talking about this Gauthron's rash or Gauthron's sign, right? So this is one example. Right? You can clearly appreciate the rash presence here, and I had told you that usually seen on the extensor surfaces, mainly on the bony prominences. So that point holds good here. Again, one more such rash on the elbows, right? So again, bony prominences, erythematous rashes. So all these are called as Gauthron's sign on the knee, on the elbow. Gauthron's sign or Gauthron's rash. Okay. Now what we see in this image, again this is Gauthron's papule. In comparison, look at the image B. You can see this is a SLE rash, so it is affecting the phalanges, sparing the interphalangeal joints, right? Sparing the interphalangeal joints. That is very typical of SLE associated rash. Okay. And what we see in the third image is presence of some capillary, nail fold capillary changes. I think you can clearly appreciate these nail fold capillary changes in this area, right? So particularly presence of this anti-synthesis antibody, I have told you, right? It makes the disease behave like systemic sclerosis, and you can have all those manifestations. So that is what it is. Nail fold capillary changes. Okay. So what we see in the next image, this is again a shawl sign, nothing specific here. But the next image that I'm showing is particularly important. This is, some of you might call this as mechanic sand, but let me tell you, this is not mechanic sand. In mechanic sand, there may be fissurings on the volar aspect, but mostly mechanic sand will have the changes on the lateral aspect of the fingers or digits. Here, you are seeing rashes which are similar to Gauthron's papules, but on the volar aspect. So we call this as inverse Gauthron sign, inverse Gauthron sign. Okay, now this is quite a rare sign, not usually seen, but we should remember particularly about this because this correlates with two things. Inverse Gauthron sign correlates with two things. What are those two things? It correlates with poor prognosis, and it is associated with extremely high risk of rapidly progressing interstitial lung disease. And when I say that rapidly progressing interstitial lung disease, I also mean this correlates with anti-MDA5 antibody positivity, right? So this is called as inverse Gauthron sign. So we know Gauthron sign, we know Gauthron's papule, we know shawl sign, we know neck sign or V sign, right? We know how to differentiate between the SLE, we know heliotrope rash. Now let us look at this next image. What we see here is on the volar aspect, you might have seen that there are some degree of fissuring changes present, but most characteristically look at the lateral aspect. There is some scaling and fissuring, right? You can appreciate a fissuring here and there is scaling. This is what we call as mechanic's hand, right? What we call it as mechanic's hand. Now, mechanic's hand correlates with what? It correlates with the increased risk of interstitial lung disease. It correlates with the increased risk of arthritis, right? And little more precisely, it correlates with anti-synthetase syndrome, right? So it correlates with the presence of the anti-synthetase antibodies. Okay, this is mechanic's hand. Now, what we see in this image is what we call as Holster's sign. Okay, so for whatever images we have seen, mostly the rashes were located on the areas which are generally have a tendency to get sun exposed, right? But we shouldn't be under this myth that the rashes that we see in IIMs are all in only in the sun exposed areas. We might have rashes in non-sun exposed areas also, and this is one classical example, what we call as holster sign. Why we call it as holster sign? We call it as holster sign because the location, look at this, right? On the lateral aspect of the thigh. And this is the location where often we might hold our guns, right? The holster. That is why it's called as holster sign. Okay. So that is about it. Now the last sign I'm showing is calcinosis cutis. Obviously, when I say calcinosis cutis, I think the systemic sclerosis comes to your mind first. And obviously, I had told you one point, right? When you have this antibody, you should think that the whole disease is going to behave like systemic sclerosis. So what antibody I'm talking about? Yes, having this calcinosis cutis correlates with anti-synthetase antibody positivity. And one last point I want you to remember about this is calcinosis cutis is particularly more common and more severe in patients with juvenile dermatomyositis than the adult dermatomyositis. Okay, so that completes our journey of cutaneous manifestation. All of these images are particularly important, and all the correlations that we discussed are particularly important. Now let us go to discuss the involvement of muscle. So when we talk about the muscle involvement, obviously few things are already clear. We are talking about symmetric involvement. We are talking about proximal more than distal or proximal predominantly affected with an exception, right? So there is an exception for both the symmetry as well as proximal involvements, and I'm talking about inclusion body myositis, which is usually asymmetric. Weakness is asymmetric, and second, it involves proximal plus distal both. Okay, so I hope that is clear. Otherwise, most other disorders are causing symmetric and proximal muscle involvement, and this muscle involvement is generally characterized by increased inflammatory infiltration when you do biopsy, inflammatory infiltration, and in terms of lab test, this manifests with extremely increased CPK levels, right? CPK levels are quite high. Obviously, the highest CPK levels we encounter in immune mediated necrotizing myopathy, but overall the CPK should be elevated. So you will in fact consider or use the CPK values to differentiate between those metabolic myopathies like hypothyroid or diabetes associated myopathies, or say hypokalemic myopathies, or in general metabolic myopathies from the immune mediated inflammatory myopathies, is basically looking at the CPK. CPK grossly elevated, you are thinking of IIMs. CPK modestly elevated or not elevated at all, you are thinking of the non-inflammatory myopathies. Okay. Now, when we do the biopsy of these disorders, we will be seeing some characteristic findings, and we have to remember them. The normal muscle, like you all know, is arranged in different fascicles, right? Multiple fascicles containing different muscle fibers. So multiple muscle fibers are arranged in, right, different band of fascicles. So you will have multiple such fascicles forming a muscle. Now, when you look at the dermatomyositis, what you will notice is what we call as perifascicular atrophy. Now, when I say perifascicular atrophy, that means you have this classical fascicle where there are multiple muscle fibers present, right, at the edge of these fascicles. Right? That is why we are calling it as perifascicular atrophy. So, if you look at this fascicle, this is how normal muscle would look like, as if it is a neatly arranged pavement separated by a road. This is the fascicle. This is the boundary of the fascicle. Now here, towards the edge of the fascicle, both the sides, you can appreciate this, the muscle fiber size has shrunken, right? This is what we call as perifascicular atrophy. So if there are two fascicles, towards the edge of this fascicle, towards the edge of this fascicle, the muscle fibers are atrophied. As you move away from the fascicle boundaries, the muscle fibers are of normal size. That is one finding, perifascicular atrophy. Second thing we can notice in dermatomyositis is perivascular inflammatory infiltration. Perivascular inflammatory infiltration. So this is a vessel we can appreciate here, and it is infiltrated by the inflammatory cells. Inflammatory cells here are B cells, lymphocytes to be more simple, B cells and CD4 plus T cells, and very minimal CD8. CD8 is very minimal. Extensive CD8 infiltration is very typical of polymyositis or inclusion body myositis. Okay. So what we see, perivascular atrophy, perivascular inflammatory infiltration, and if you again look closely, you might notice that there are inflammatory infiltrates between myofibrils, not inside the muscle cells, right? So these fibers are not invaded. The fibers are invaded in polymyositis. Okay, that is one more point to note. Now, when you look at the biopsy picture of polymyositis patient, what you notice is the different muscle fibers or the cells are of different size. Unlike here, if there is atrophy in the perivascular region, otherwise the cells are of decent size when you move away. Here, the cells are of different sizes because different cells are being attacked. Mainly, the healthy muscle fibers are being attacked, invaded by the inflammatory cells. You can notice here they are being invaded. So, those inflammatory infiltration will leave these cells atrophied. So you will have different muscle fibers sizes, right, in the same biopsy specimen. And the second finding is invasion of the muscle fibers by the inflammatory cells. Okay, that is typical of polymyositis. So here we don't have this classical perivascular atrophy, right? Okay, that is polymyositis. In this image, I think you can clearly appreciate. You look at the muscle fiber sizes here and look at the muscle fibers in this region, right? So if you get this biopsy picture, the diagnosis is pretty straightforward. We are dealing with dermatomyositis because we have perivascular atrophy here, right? Okay, now what do we see in patients who have inclusion body myositis? Inclusion body myositis. In inclusion body myositis, first thing is there may be CD8 T cell infiltration, CD8 positive T cell infiltration. And second thing, classically we will have inclusion bodies, okay, and degeneration of muscle fibers giving rise to what we call as rimmed vacuoles. Rimmed vacuoles. And we will be able to appreciate these rimmed vacuoles when we use Gomori trichrome stain. Okay, that's about biopsy. Yeah, one last point. This biopsy, especially dermatomyositis, might immunostain. When you do immunostaining, they may immunostain for something called as myxoma resistance protein. Myxoma resistance protein A. Right? You can simply remember it as MYXA expression. So this is again MYSA expression should prompt you to think of the diagnosis as dermatomyositis. Okay, so that completes our biopsy. Now let us talk about the lung manifestations. What are the lung manifestations? So lung manifestations, you might see both the UIP as well as NSIP. You might see NSIP as well as UIP kind of interstitial lung disease. And lung manifestations classically correlates with presence of two antibodies. One is anti-synthetase antibody, and the second one is, as we have already discussed, anti-MDA5 antibodies. Okay, between these two, when you have the ILD associated with anti-synthetase, it is usually going to be mild. When it is associated with anti-MDA5, it is going to be rapidly progressing. Rapidly progressing. Particularly this MDA5 antibody positive patients, when they develop ILD, the 3-month survival is usually considered to be less than 60%. So it is a very rapidly progressing ILD that we see in these patients. So obviously when we say rapidly progressing, mostly it will be UIP type, right? Okay, so antibodies are clear. There is no confusion about that. Now let us move to the next organ that is involved, that is cardiac involvement. Now in terms of cardiac involvement, we can see the patient presenting with myocarditis. Though cardiac involvement overall is rare, myocarditis is known to occur. And the second thing, you might see subclinical picture, subclinical cardiac involvement, mainly in the form of conduction abnormalities. Conduction abnormalities. Okay. Anyway, both are quite rare only. From the exams perspective, I want you to remember presence of anti-SRP antibodies correlates with the cardiac involvement. Okay, so I hope that is clear. Now, coming to the malignancy. Yes, this is particularly important for us. Now, some of these idiopathic inflammatory myositis are considered as pre-malignant, right? And the disorder that leads the pack is dermatomyositis, right? Then polymyositis, not very strongly associated with, but still we should remember that there are case reports of malignancies originating in patients with polymyositis. Okay, That is second. Inclusion body myositis can also be associated, but classically we have to remember it is dermatomyositis. Now, what malignancies these disorders are associated with? These disorders are associated with colorectal malignancies, colonic malignancies little more precisely. Then they are also associated with ovarian malignancies, and third, head and neck cancers, right? Head and neck cancers. Now, when it comes to India, it is the head and neck cancers that is most commonly associated with IMs in India. Okay. Overall, I am not really sure because some sources say it is ovarian, but the standard sources, which I personally believe, generally say the colon malignancy, which is highly associated with dermatomyositis. Okay, so that is clear. Then one more point we have to learn is antibodies that correlate with the malignancy risk. Antibodies that correlate with the malignancy risk. So the number one is obviously anti-TIF1 gamma antibody, right? This is something that you have to remember. The second thing is also anti-NXP2 antibodies. Okay, so at least remember this one, anti-TIF1 gamma antibodies, which are very strongly associated with, or it is almost considered as a marker of malignancy in patients with dermatomyositis or any of the IMDs. Okay, so with that, the last discussion, it is about arthritis. So remember, it is arthritis which is likely to behave like SLE associated arthritis. So this is a non-erosive, okay, non-erosive inflammatory arthritis, mainly affecting the small joints of the hand. It mainly affecting the small joints of the hand. So for that matter, it kind of behaves like RA or SLE, but obviously it is non-erosive, so it is more behaving like SLE, right? So it is usually non-deforming. Okay, so that is with respect to muscle involvement. Now coming to diagnosis, what do we all need for the diagnosis? So for the diagnosis also, traditionally for many years we used to follow this Bohan and Peter diagnostic criteria. Bohan and Peter diagnostic criteria. So according to this diagnostic criteria, we required five things. The first thing that we needed was presence of symmetric muscle weakness. That was the first thing that we would need, symmetric muscle weakness. Then second thing we needed was evidence or biopsy evidence of muscle weakness consistent with the diagnosis, or the EMG findings consistent with the diagnosis. The fourth thing we needed was a CPK or other muscle enzymes which are elevated. That apart from CPK, what are the muscle enzymes? Aldolase, LDH, and also AST. Right? AST, if you remember from my hepatology lectures, you might have already noticed that AST has extrahepatic sources. Right? It can be expressed in muscle, it can be expressed in RBCs and various other tissues. So it can also be considered as a marker of muscle injury. Right? The fifth thing we required was, for especially for the diagnosis of dermatomyositis, is classical or the diagnostic DM skin changes. Right? Diagnostic dermatomyositis skin rashes. The three rashes we have already spoken about: Gauton's papule, Gauton's sign, and heliotrope rash. Right. So based on this, the disease used to be classified as dermatomyositis or polymyositis. Okay, so today basically what we do is, first thing we have to do is roll out all the closely related differential diagnosis and endocrine myopathies or any other myopathic conditions based on the clinical examination history and if required supported by the laboratory. Then we look at the CPK levels. This primarily we are doing it to differentiate between the inflammatory and non-inflammatory myopathies. CPK levels which are usually more than 1000 are very classical of the inflammatory myositis. When it is under 700 or 800, we are actually in a gray zone. Further information or further examination findings or evaluation may be required in that case. But when it is 2000 plus, it is almost certain that you're dealing with a inflammatory myositis. Okay. Muscle biopsy is not considered as mandatory in all cases, but it is definitely helpful in differentiating these different types, right? So we have discussed the classical findings on the biopsy. It is considered as mandatory in cases where you are suspecting or you are unable to differentiate between polymyositis and inclusion body myositis. Particularly when you have polymyositis, IBM remains an important differential diagnosis, especially because patients do not have the classical skin manifestations. So in that case, you might require that too when you are having a patient who is 50 plus. Okay, so that is about the diagnosis. Now, this is a very quick summary of all the antibodies we have discussed so far so that you can just remember it. Starting with anti-ARS, which is nothing but anti-synthetase antibodies, anti-amino acyl RNA synthetase, that is what ARS stands for. So, anti-synthetase antibodies, anti-Jo1 is the most common among them, and this overall this is the most common antibody that we see in dermatomyositis patients, right? That, as I've already told you, correlates with the polymyositis more than dermatomyositis and anti-synthetase syndrome. When we say anti-synthetase syndrome, patients having fever as one presenting feature. I think I did not to tell you this. Fever is a very frequent presenting feature in patients with the anti-synthetase syndrome, so we have to remember that. Okay, fever, then Raynaud's phenomenon, arthritis, interstitial lung disease. These are the things that anti-synthetase correlates with, right? Then anti-Mi2, one of the helicase group, which is targeted against NURD subunit, which is very classical of DM, right? So I have already told you that is kind of the helicase groups are typically seen in DM cases only. Then anti-TIF1 gamma, we are already clear now that it is cancer associated, right? And also correlates with the severity of the DM disease. Anti-NXP2, again DM, again cancer associated. Between these two, I have already told you TIF1 more strongly. Then coming to next, anti-melanoma differentiation associated antibody or anti-MDA5. It can be correlating with the amyopathic DM or interstitial lung disease, right? This is particularly something that I want you to remember, and it is associated with poor prognosis. That is also something that I want you to remember. Anti-SAE is actually an antibody targeting the SUMO1 activating enzyme. Again, one more DM specific antibody. These patients also initially may be amyopathic. Anti-SRP, we have clearly understood, right? Anti-SRP correlates with one thing is cardiac involvement. Yeah, the other thing I forgot to tell you is that it correlates with the necrotizing myopathy. So this is something which is also seen in immune-mediated necrotizing myopathy, apart from patients with the dermatomyositis, right? It can be seen in immune-mediating necrotizing myopathy. The last one is anti-HMG CoA reductase. We will talk more about it. That also correlates with the necrotizing myopathy, particularly on exposure to statins, right? So this is one table that you have to literally remember to crack so many MCQs. Okay, so now coming to the individual types of the idiopathic inflammatory myositis. Let me first talk about dermatomyositis. Only quick revision points. We are already aware about the skin manifestations plus inflammatory myositis. Right? You will consider it as dermatomyositis. It is associated with increased risk of cancers, right? Particularly colonic malignancies, then head and neck malignancies, and also ovarian and breast malignancies, right? That is one point to take home. Then talking about the next entity, that is polymyositis. Polymyositis is usually only muscle involvement. There is no skin involvement. Okay, the other thing it differs from dermatomyositis is in terms of antibody profile. It is more likely to be associated with anti-synthetase syndrome in comparison to patients with dermatomyositis. Okay, then coming to the third thing, this is particularly important, inclusion body myositis. The rule of exceptions start applying here now. It is more common in males than females. It is involving both proximal and distal. So when I was talking about dermatomyositis and polymyositis, it is predominantly proximal weakness, right? So now comes the condition where there is proximal plus distal weakness. And the most common presentation of the inclusion body myositis is, I think if you remember earlier also I have told you, it is usually asymmetric. Mostly it affects proximal and distal, and when we talk about proximal, it affects lower limb more than upper limb. And lower limb, the initial changes are noted in the quadriceps group of muscles, right? So because of that, patients might present with the progressive weakness of the quadriceps, leading to difficulty in walking or frequent falls, right? Leading to difficulty in walking or frequent falls. So when a 50 plus presents with difficulty in walking and frequent falls, someone who is 50 plus in age, and you do a CPK levels are usually not elevated grossly, right? So then you would be thinking of inclusion body myositis as one of the differential diagnosis. So again, remember, with respect to CPK, here is an exception. The CPK levels are only minimally or no elevated at all. right? All the more reason to think this condition as a degenerative disorder than the myositis. Okay. Apart from that, yes, these patients may also have dysphagia because of the involvement of the pharyngeal muscles. It can be seen, pharyngeal muscle involvement can be seen in dermatomyositis or polymyositis also, and it can be seen in inclusion body myositis also. Okay, the last point to note about IBM is again one more exception. There is no increased risk of interstitial lung disease. It is not associated with malignancy, and it is not associated with any particular cardiac disorders. So there is no other organ involvement as such in this case, right? So that summarizes the inclusion body myositis. Now coming to the next important individual type, immune mediated necrotizing myopathy. And this is so for whatever we discussed, no, all of them are either subacute or chronic in terms of presentation, but this is something which presents as an acute entity. Acute onset myopathy, right, characterized by very high CPK levels. CPK levels exceeding 3000 are a norm. CPK levels exceeding 3000 are a norm. Okay, when you do the biopsy, you will notice that it is characterized by necrosis without the inflammatory infiltration. So when I was talking about this inclusion body myositis, I said it is usually associated with normal CPK. Here the CPK is extremely high, but you don't see any inflammatory infiltration. In inclusion body myositis, we do see CD8 positive T cell infiltration there, right? Without inflammatory infiltrates. That is a characteristic finding we should be aware about. Okay, and if you look at their antibody profile, I have already one point we have told, that is anti-SRP antibody that correlates with the necrotizing myopathy, and so that is one point we should know. But particularly when statins are precipitated, now statins are the most important cause for immune mediated necrotizing myopathy or myositis. Then when it is statin precipitated, it is usually associated with anti-HMG CoA reductase antibodies, right? So statins cause two types of myopathies. One is non-inflammatory myopathies where the CPK elevation is modest. That is the most common statin-induced muscle disorder. This is rare. Immune-mediated necrotizing myopathy is rare, but the more severe form of statin-associated myopathy. Okay. Now this is one table that summarizes all the points we have discussed, and you can use it for your revision. If you talk about dermatomyositis, it can occur in adults and children, usually subacute, proximal, symmetric. There are systemic features, skin changes present, calcinosis can occur. I have already told you calcinosis is more common in juvenile dermatomyositis than adult onset dermatomyositis. Okay. Then it might be associated with, it may be part of the overlap syndrome. Malignancy association is strongest among all the things that we have discussed so far. And lab features will say usually normal to high serum CPK levels. EMG will be abnormal in all these, that is secondary. Biopsy findings we have already discussed. Okay. When we talk about polymyositis, adults only, not in pediatric age group. Subacute, usually proximal, symmetric. Yes, there is involvement of systemic features. Malignancy changes, yes. Malignancy association is present, but relatively rare, not very common, right? Skin changes, no, we are not expecting skin changes to see. Calcinosis, very, very rarely. Okay, biopsy findings we have already discussed. Now coming to inclusion body myositis, adults 50 plus. I repeatedly keep telling this, adults 50 plus, it is a chronic disorder. Selective pattern asymmetry mainly affecting the quadriceps, patients presenting with frequent falls, right? Okay, so that kind of summarizes all the points we need to know. So with this, we will now move to discuss the management of the disease. Now when it comes to management of any of the inflammatory muscle diseases, we can talk a little more specific about the immune-mediated necrotizing myopathy where the drug needs to be withdrawn and maybe we need to treat the condition more aggressively, but let me give you a very simplistic overall approach. When we talk about inflammatory muscle diseases, the mainstay of treatment is steroids. Mainstay of treatment is glucocorticoids. Okay. Very often, patients might require a combination of glucocorticoids. So that is the mainstay of treatment. Plus we might have to combine with other immunosuppressants. Now the second immunosuppressant depends on the severity, whether you want to use conventional like methotrexate or azathioprine or a little higher agent, and whether you want to combine with IV immunoglobulins or plasma exchange. That depends on the severity of the disease. Okay. So this is a table that gives you a very quick idea about the management. The first line management includes glucocorticoids as standard part of the template plus As a first line agent, immunosuppressant, either you can pick up methotrexate or azathioprine. And if it is a severe disease that you're encountering, maybe you can also combine IV immunoglobulins, right? So most cases, how we manage, we give them steroids plus either methotrexate or azathioprine. That is how most patients get the prescription. As a second line agent, when your first line therapy fails, right, as a second line agent, glucocorticoids anyway you will be continuing, but you can either use combination of MTX plus azathioprine. So let me just give you a quick summary. First line, what we can use, we usually use glucocorticoids plus methotrexate or azathioprine plus or minus IVIG depending on the severity of the disease. The second line options include glucocorticoids, a standard part. You can use methotrexate plus azathioprine as a combination. So initially we had to choose one between the two. Now we are combining both, or alternatively you can use mycophenolate, mofetil, or tacrolimus or cyclosporin. Right? That is our second line agent. Now when we talk about third line agent, again you are continuing glucocorticoids plus, as a third line agent you might consider using rituximab, or you might consider using cyclophosphamide. Okay, IVIG remains an add-on option, right? Plus or minus IVIG remains as an add-on option in all these cases. Okay, apart from this IVIG, in more severe cases you might also consider pulsed steroids. More severe cases, pulsed steroids, obviously when I say pulsed steroids I'm talking about methylprednisolone, usually 500 milligrams to 1 gram IV infusion OD for 3 days whenever there is more severe initial flare-ups, and once you have a control, obviously you can switch over to the conventional regimens that we have discussed here. Okay, so that concludes our session for the day. I will be again taking up one more important topic soon. Thank you all.